Hello, I'm Caroline Fairchild, and welcome to Working Together Live, a show about equity in the workplace with the leaders changing the face of business. Before we get to today's show, I want to acknowledge the news coming out of Ukraine. Like many of you, the LinkedIn news team is following the story closely. For more information, be sure to check out the news module to the right of your LinkedIn feed. The pandemic shined a bright and glaring light on a long-standing reality. The American health system is filled with inequities, and the leaders shaping what care looks like and what patients get care often does not reflect the patient population. What needs to change to make healthcare more accessible and equitable for all communities? Joining me now to discuss is Toyin Ajayi. She's the co-founder and president at Cityblock Health, a startup that works with your insurance provider to address gaps in your care. Prior to founding Cityblock, Toyin held positions at Sidewalk Labs and the Commonwealth Care Alliance. She also practiced family medicine at Boston University. She got her BA at Stanford, her Doctor of Medicine from King's College London. She also has a master's from Cambridge University. Toyin, welcome to LinkedIn News Live.
Thank you. Thank you for having me.
It's great to see you. I've been looking forward to this conversation. I feel like I booked this with your team many months ago, so I so appreciate you joining us. Let's just start with Cityblock. You mostly work with marginalized groups, and you have a very ambitious goal of reaching 10 million patients by 2030. What was the opportunity that you and your co-founders were trying to address with this startup?
Yeah, I think, as you said in your intro, the pandemic has really shone a light on all of the historical pre-existing inequities in our healthcare system. The reality is that people of color, lower income folks who struggle with disabilities, with mental health challenges, with substance use challenges, have always received really subpar care relative to others and have, as a result, received much, much, much worse outcomes, ranging from life expectancy to their experience of healthcare. And there's a real opportunity, we know this, to deliver a significantly improved experience of care that's respectful, that's dignifying of the individuals whom we seek to serve, and most importantly, that results in better outcomes. And so we saw an opportunity 4.5 years ago now, as we were building Cityblock, to deliver an experience of care to marginalized communities that focused on interdisciplinary care for primary health needs, for behavioral health, and for social health needs, that was really oriented towards shifting the paradigm and driving better outcomes across the board.
And I saw a talk that you did back in 2018, which is pre-pandemic, so it might as well have been a decade ago. But you centered your conversation around Cityblock on this topic of trust and the importance of trust in terms of how people make decisions and how they react to institutions like the healthcare industry. Talk to us a little bit about trust and how it relates to how you founded Cityblock and the opportunities in terms of healthcare becoming more equitable.
Yeah, so much of the founding of Cityblock and our care model and our values is rooted in our experiences as healthcare providers. I'm a physician. My patients have been my greatest teachers. And so often what they said to me is, despite the fact that we are in the United States so privileged overall in terms of our access to incredible healthcare technologies, specialty centers of excellence, our understanding of public health, so many of my patients were not able to actually access these health services, partly because they were not designed for them. And I can talk more about what that means, to actually be designed with their needs in mind, with their constraints and their opportunities in mind, but also because they weren't trustworthy. People were reluctant to seek healthcare, even when it was accessible to them, because they didn't feel like it was designed to be trusted. It wasn't dignifying of them. It wasn't aligned with their needs and their interests. And that fundamental desire and recognition that we have to show up with humility, with trustworthiness, if we seek to change outcomes for the populations whom we serve, was such a core tenet for how we built Cityblock.
Let's talk a little bit about how Cityblock is different. I want to talk specifically about the community health partners that in many ways disrupt how healthcare decisions are made for patients. Talk to us a little bit about those and what role they play in terms of trying to solve some of the inequities that we're discussing right now.
Yeah, so we have hired and really scaled up a workforce of folks called community health partners, who are individuals who are from the communities we serve. They often have lived experience of parts of the experience and the journey that a lot of our members have as well. They are hired for empathy, for their expertise in understanding and accessing community resources, for their tenacity, and for their ability to really build and sustain trusted relationships. And with our community health partners, we're able to show up for and with our members in a totally different way than healthcare typically does. Not in a sort of top-down, you must do this, these are the prescriptions you must take, you must exercise, you must fill in the blank, in the sort of directive way that healthcare often shows up for people, but in a way that really understands that we've got to walk alongside our members. We have to accompany them. We have to earn the right to show them a different path such that they may choose and make different choices. And that shift in the power dynamic between Cityblock as a healthcare organization and the members whom we serve is so fundamental. And our community health partners really help to broker that shift, because we're not doing things to people. We're not here in some sort of like benign, benevolent, but patriarchal way to sort of do things for people. We're walking alongside our members, and we're really helping to support and escort them as they make choices for themselves, recognizing that they are the experts in themselves and their health and their life.
When I first heard of this concept of community health partners, I thought it was so refreshing and novel, because like you said, it does change the patient care model away from this top-down approach. But I also had this question. It also takes away some power from physicians who are pretty much responsible and have been historically for making a lot of these decisions alone. I'd be curious to hear about what the response has been from doctors, from physicians who you're saying, hey, we want to do this differently. We want to bring more people into these discussions.
Yeah, I think it's such a good point, and it's a really important point, right? Like there's a deliberate effort here to shift power away from the people in the white coats, people like me, doctors who historically have held a lot of power in the healthcare system, and towards the patients and the community members we're seeking to help. And I think that that it's been really well received. I mean, our clinicians at Cityblock understand that we cannot force our will on other people. We cannot force our desire for someone to take their insulin, to manage their diabetes 3 times a day onto them if they don't have enough food to eat, if they don't understand the healthcare instructions, if they can't afford the medications. Like, we cannot want it more than they want it. But what we can do is sit back and listen. And if we listen and we show up with humility and with a real desire to respect and honor the autonomy of our patients, our members, maybe they'll share with us what their barriers are. And maybe we get to participate in helping to solve those barriers so that they can make the choices and take actions that are different. And I think it is in many ways very empowering for both parties when we operate in this model, because physicians have long really struggled with the idea that they have to solve all these problems for people, that they're accountable for a host of social challenges and behavioral health challenges and social constructs that they don't have any power over. And that's the truth. We don't have power over them. But if you partner with your patients, with your community members, with other members on your team, your community health partner, your behavioral health colleagues, you can actually help find the right solution and help shepherd people through that path. And so we actually, what's so, I think, rewarding and gratifying for clinicians in this model is you can actually deliver better outcomes. You see the results in the outcomes. And ultimately, that's what we're here for. We came to this work to help people achieve their best version of their life. And that includes health, but it also includes dignity and respect and social services. And so being able to make sure that we can be part of that journey has been so powerful for people.
You mentioned the importance of listening, and I think everyone who's joining us in the stream right now would agree that they hope that their physician is listening to them. But there is a comment that you've made in the past, this common phrase that countless patients, particularly marginalized and underrepresented patients in terms of caretakers and caregivers in the healthcare system, that a lot of people say, which is, I know something is not right. I can feel that something is not right. And unfortunately, that is one of the most ignored phrases by healthcare professionals. What is happening there? Walk us through some of the biases and some of the systems in place right now that are preventing physicians from doing what you're saying, which is just listening.
Yeah, no, I think there's been so much research about this, and I'm so grateful, I think, for the just incredible researchers who've been surfacing all the different ways in which this bias shows up. More often than not, it is not out of an intentional, conscious desire on the part of the clinician to not listen, but because so much of what we do in medicine is actually about heuristic patterns. It's about saying, when I see this combination of symptoms together, I suspect X or Y medical problem may be going on. We default to some of these more lazy and innate patterns of decision making. And what that means is that when a person encounters a patient who represents either a demographic or a physical profile or a social class that the clinician themselves associates with a certain number of attributes, they're often defaulting to decisions and to understandings of what's going on for them that are not tied to what the patient is listening to. So I'll give you a perfect example. And there was actually recent data to support this, that patients who are Black or brown are more likely to have labels in their chart, in their medical record, that describe negative descriptors, pejorative descriptors, descriptors that blame patients for their own illness, are more likely to happen for Black patients, 2.5 times more likely to happen for Black patients than white patients. And that's not because Black patients care less about their health. To the contrary, actually, when you survey folks, people who are most marginalized actually care the most about health. But it is because clinicians have ingoing biases that are unchecked, and the power of those biases to impact the way that people care for patients, it's a matter of life or death for many patients. And so, so when I look at my folks, the folks I care for, who are more likely to be people of color, who are more likely to be women, who are more likely to be folks with a diagnosis of a mental health challenge in their chart already, who are more likely to show up with perhaps clothing or a living situation that represents their marginalization. These are exactly the people who the healthcare system is most likely to stereotype, pigeonhole, to not listen to say they're malingering, they didn't take their meds, that's why they're not feeling well. They
one of those labels is in the chart that you just mentioned that are biased, has to do with not taking your meds.
That's right.
What is that called?
Non-compliant is such a oft used term. Yeah. And it just like see the judgment that sort of underpins it. I mean, it's so profound. We would say that to our patient, you know, we give you a label because you didn't do the thing we told you to do, without asking why not. Like, what happened? What's going on for you? Were the instructions bad? Did they not make sense? Do you have the resources and capabilities and the tools to do the thing that we asked you to do? Do we need to restate it? Do you have a different priority that we didn't hear? Like, there's so many reasons why someone wouldn't take their meds. But to assume that it is because they willfully chose not to, because they are non-compliant with what I told them to do, is so damning and so endemic in healthcare.
Absolutely. And we've talked a lot about some of the systemic biases that lead to patients being labeled non-compliant in their chart, leading to even further biases. But what about the finances of this? Healthcare, as we all know, is expensive. I'm curious how that comes into play in terms of trying to figure out how Cityblock can more effectively work with patients to make sure that they can even afford the finances and the medication that they need in order to get better.
Yeah, absolutely. I mean, we can start in healthcare, but actually we need to go upstream of that. Like, being a human being and being a healthy human being, or a human being who has the tools that they need to be healthy in this country, is expensive. So before we even get to healthcare, remembering that most of healthcare delivered in this country is reactive. It's care that we deliver once you have already developed an illness, when you go to the emergency room, when you go to the hospital, when you already have the diagnosis of the diabetes or the high blood pressure and you're taking medicines to manage it. But way before that, the things that actually help us promote well-being and health, those are expensive. Adequate housing, access to clean water, access to green leafy places to go walking outside, to fresh air without pollution, to food that's healthful and affordable, to transportation to get to and from your primary care office where you're more likely to get preventive care. Like, all of that stuff. And again, it is racialized in this country because of the history of systemic racism in education, in housing, in access to jobs and income security, in wealth generation. Like, it just pervades even before we talk about the front door of what has traditionally been healthcare. And then you cross the front door of what's traditionally been healthcare. You are a patient with 3 or 4 chronic conditions. You've now developed the diabetes or the high blood pressure or the kidney disease, and you're accessing the healthcare system. Remember that the way that we reimburse for healthcare biases towards paying more for reactive, more expensive care. The emergency room visit, it's paid for more than the primary care visit. The hospitalization, when your diabetes gets so bad that you then need an amputation of your infected limb, it gets reimbursed way, way higher than the mental health visits that may have helped you cope with your life and take your meds more effectively. And so we've created a system that is entirely perfectly fit for purpose to deliver the outcomes that it delivers. Like, inequity is baked into our system of healthcare traditionally. And so when you start to take that apart and ask our patients, what are the biggest challenges that you face to health, to living the life that you want for yourself and for your family, and you peel the layers back, you start to understand that it is not just about healthcare. It's about health, and it's about primary care. It's about mental health. It's about social services. It's about connection and relationships. It's about having a voice to be able to say when you don't feel well and have someone take you seriously. It's about access to income and transportation. And so starting to pull all those pieces together and get as far upstream as we can in order to deliver the types of holistic services with an empowered approach to engaging our members is a critical part of how Cityblock operates. We're really trying to sort of break that cycle as far upstream as we can by focusing on folks who are most marginalized and have the most to gain and often the most to lose by the existing system, the status quo, and the way that it treats them.
I think that is so important to realize that there are layers to this, and healthcare is not living in a silo in terms of the problems that marginalized groups are facing. And those layers that you discussed, Toyin, those really came to a front at the start of this pandemic and continue to bear out in terms of the infection rates with COVID, as well as the mortality rates across different races. Talk to me a little bit about, from your point of view, leading Cityblock. How has the pandemic changed what you've been focused on? What were your initial reactions to this healthcare crisis?
Yeah, I mean, like everyone, the initial reaction was just this deep sense of fear and sadness and loss of the sort of life and the ways of being that we had known before. I think for us, it became very obvious very early on, because of the population that we serve, that our members were the ones who were most likely to be left behind. They were the ones who were most likely to suffer disproportionately from the pandemic. We serve a population of folks who are lower income, folks who live with multiple chronic conditions, folks who struggle with mental health and physical health and social needs, folks who are predominantly people of color. And we recognize that when the pandemic hit, that their neighborhoods, their communities were going to be least likely to have access to life-saving medications and to treatments, that their communities were going to be least likely to have access to the food and other social services that folks needed to stay safe, that our members and their families are more likely to be essential workers who would have to leave their homes every day in the middle of the height of the pandemic in order to earn a living. And so much of what was happening from a public health standpoint really wasn't going to work for our people, because they couldn't work from home and continue to make a living. They couldn't, switch their everyday patterns in order to avoid exposure. And when they did become ill, they were often accessing healthcare systems that were already overstretched and under-resourced at the beginning. And so what it meant for us was really further intensifying our efforts to get as close to our members as possible with an experience of care that, of course, as always, is respectful, dignified, and trustworthy, and with clinical tools that enabled us to really, really meet the needs that they had and close the gap around their most pressing concerns as quickly as possible. Yeah. And for us, what that meant was providing more care in the home, even than we'd been doing before. It was always part of our model, but really intensifying that work, expanding out our clinical capabilities to make sure that we could take care of folks all the way up until effectively an urgent care visit in your home, expanding our 24/7 capabilities, leaning further into virtual care, really doing everything that we could to help ensure that the fact that we were restricted around our movements, around our ability to kind of receive care in bricks and mortar traditional spaces wouldn't in any way impact our ability to care for our members. And in fact, what we saw during the pandemic is that we increased our touch points with our members. We increased the number of visits we provided to them. We increased the level of engagement with them because we were able to show up at a time when they needed us with more intensity rather than less.
Mm. Well, Toyin, I see a lot of people in the stream who are very appreciative of the work that you're outlining right now. I just want to say a quick hello to them and bring them into our conversation. Kelly says, I also think access to early childhood education is a huge barrier and contributes both to health and education inequities. Karen says, rural America still has limited access to healthcare. And Daryl says, great convo. As an insurance professional, I see similar inequities. So Daryl, Karen, and Kelly, thanks for joining us on this show. Toyin, I just want to point to some of the numbers that we saw in terms of the health outcomes across racial lines when it comes to COVID-19. This, if anything, had to have been a moment where healthcare professionals are realizing just the importance of making sure that some of the inequities we've been discussing on this show are solved. Are you at all confident that healthcare professionals are waking up to the fact that the ingrained biases and systemic issues that are within healthcare are things that need to be fixed and needs to be fixed rapidly?
It's hard to make a blanket statement there. Like I think we have certainly seen way more discourse about this in recent years than at any time before, right? Like none of these data are new, right? And none of them have shifted in the last 20 years. So we just need to sit with that. We've known all of this is true for a very long time. It's been 20 years since the Institute of Medicine published the landmark study called Unequal Treatment that looked at disparities in health outcomes. And basically none of the stats have shifted for the better. In fact, maternal mortality and the Black-white maternal mortality gap has worsened in that time period rather than improved. So I want to believe that that given the information, with the level of understanding and nuance we have about the determinants of health outcomes and the inequities baked into our healthcare systems, that clinicians are finally listening. But you have to recognize that this is, as I said before, this is not about individuals making choices on a day-to-day basis to harm their patients on the basis of their skin color. That is rarely what's happening. What's happening is that our systems are structurally set up to deliver the outcomes that we see today. And that means that not only do we have to sensitize individual doctors and nurses and administrators and healthcare professionals within the system, we actually have to change the systems, fundamentally shift them. And I think we're starting to see for the first time real action there, real movement in terms of large healthcare organizations taking on equity meaningfully, putting resources behind it, interrogating their policies, their processes, and the way that they work, and starting to make motions in that direction. But this is a systemic thing that actually requires real undoing in order for us to see better outcomes. And that will take time. And it takes individual will, but it takes institutional will just as much as it does anything else.
I think what worries me the most, bringing us back to the top of our conversation, was just the amount of trust that the American healthcare system needs to build right now with marginalized communities. I can only imagine that is going to take just as much time as change within the healthcare industry itself.
That's right. Absolutely. Yes, absolutely. And people trust your actions. And so you have to show up and walk the walk. And it does not help us that every time you turn the paper, there's yet another point of evidence of the ways in which so many parts of the healthcare system are not designed to address and really speak to the needs of the most marginalized folks, right? And so we've got to show up differently. And the data will demonstrate when we've gotten there. And people, our communities, our stakeholders, our patients will start to rebuild that trust once we actually show up differently as a healthcare system.
Well, the good news here is that investors clearly see the problem that you are trying to solve, which I'll have to tell you, when it comes to inequities across the board, VCs in particular cannot be awakened sometimes to these historic issues. But Cityblock has raised $900 million. You're valued at over $5 billion. Why now do you think a model like Cityblock is one that venture capitalists want to throw money behind, and that communities everywhere are saying this is something that we need to scale, and we need to scale quickly?
Yeah, I think a couple of things. I think one, if anything, the pandemic taught us that we are all interconnected. My health and my well-being is just as much dependent as my neighbors as it is anything else. We saw the extent to which the healthcare inequities in the pandemic are an indictment on all of us, on our systems and structures. And it was so pervasive and so profound that it's impossible to look away. When you add that moral compulsion to do something differently to the fact of just stark reality that the way that we deliver healthcare today is financially inefficient, it's actually wasteful. It is misaligned with a rational business case to wait for people to get sick before we then spend a whole bunch of money on reactive care, when we could have invested those dollars more efficiently in providing a much higher quality, much more personalized, much more dignified experience of care in the community, the same people. It doesn't make sense. And so when you have a convergence of both a really stark business case, it actually does not make financial sense to continue to do what we've been doing, to wait until folks get sick to care for them. It makes more financial sense to invest upstream and in the community in care services that actually deliver better outcomes over the long term. And there's an opportunity to do good societally by investing specifically and focusing on these populations. That combination with, the fact that Cityblock, we've been around before the pandemic, and we've been doing this work long enough that we're starting to demonstrate outcomes for this work, that there's a sustainable and scalable business case to investing in the care for these populations. When you add those pieces together, I think you really start to make a case that we can and should do really differently by these communities by investing in types of care models that really have the potential to shift outcomes favorably for them and for the system and society as a whole.
And I'm hopeful that we're going to see more investment in these communities, particularly when we layer onto the fact that Black female entrepreneurs, they represent the fastest growing demographic right now in terms of entrepreneurs in this country, according to a report by Goldman Sachs. And we've seen a significant uptick during this pandemic. What do you think is driving this surge of entrepreneurship under the backdrop of this global pandemic and just all the inequities that we've seen right now amongst Black females?
Oh, that's such a great question. I think first let's contextualize it. It's not all a rosy story, right? Like as you know, the proportion of venture funding that goes to Black women founders is minuscule relative to
0.06%.
It's tiny. I think the proportion that goes to women entrepreneurs and
2%.
founders, 2%, right? So we are, and this is nobody. I defy anybody to try to make an argument that this is because there's a lack of talented people, lack of talented women or women of color with great ideas that are fundable. That it's a lack of capability, that there's a lack of like you name it. It's not a pipeline problem. So we are starting from a very, 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 very low, abominably low baseline, right? And so I'm happy to see those changes. I'm happy to see that that start to shift. But we're so far away from where we should be. And so what represents that shift? I think a couple of things. I think one, certainly, and I hope that the increasing attention on equity and the recognition that we can and should be doing everything we can in every sector of our society to understand and address racism, racial bias, and racial inequity by seeking out the voices of people who have a different perspective, who are marginalized and otherwise sidelined in the conversation, and empowering them. That has to have played a role, and I see that certainly in the communities of venture capitalists that I speak with, a much greater recognition that they need to be looking outside of their typical echo chambers often for great ideas and great talent, and they should back that talent and those great ideas. Right. But I also think that on the supply side, I think a lot of people in the pandemic really took this moment to revisit what they were doing work-wise, and whether their work was bringing them joy and fulfillment, whether their work was aligned with their values. And I think there was this feeling, and we see this more broadly in terms of shifts in the workforce, if not now, then when? If I have a great idea and I'm tired of, just slogging it out at a job that doesn't value me, maybe now's the time to step out and strike on my own. And that courage, you can only imagine what it takes to, as a Black woman in particular, specifically to step out of a more traditional, perhaps safer, but less affirming, rife with bias experience in the workplace, and take your future into your own hands and strike out to do something. I mean, the courage and the dedication is tremendous. And, it's no surprise then that the bar for entrepreneurship in terms of the kinds of ideas that folks have, the grit, the determination, the hard work that I see amongst Black women founders, it's just it's unreal to see
unparalleled.
What people overcome and continue to overcome in order to be successful in this space.
Absolutely. Well, Toyin, I see so many people in this stream grateful that you persevered and went out and started this company in 2017. So thankful for the work that you're doing. Therese says, developing a relationship is key. We are not numbers. Kristen says, spot on, investing in marginalized groups and very young children is key. And Leonard says, well said, Toyin, keep it up. We're proud of you and your accomplishments and your future endeavors. So Toyin, thank you so much for joining us on Working Together Live. I so enjoyed our conversation.
Thank you. Same here. Really appreciate it.
That was Toyin Ajayi. She is the co-founder as well as president of Cityblock Health, walking us through how, particularly in this global pandemic, we can bring more equity to the healthcare industry. I want to thank her for joining us on the show. I see a lot of you are very excited to have her on. Working Together is not just a live show, it is also a newsletter that hits your inbox every Wednesday morning. So if you need more or want more on equity in the workplace and the leaders changing the face of business, subscribe by hitting the comments that are in the stream right now. Next week on Working Together Live, why do people assume leadership is all about them when really it is about everyone else? We'll talk with the authors of a new book on empowering the teams around you at work and why now, more than ever, it is essential for the workplace of the future. I'm Caroline Fairchild. Thank you so much for joining us on Working Together Live.